pan-PI3 kinase inhibitors and showed disappointing results in a randomized phase 2 study with pictillisib, a pan-PI3 kinase inhibitor. The next studies we saw were phase 3 trials with buparlisib. And as you can see here in the lower left-hand curve, there is no difference in progression-free survival with this agent, and there was significant toxicity, including depression, hyperglycemia, rash, and most significantly in my patient population, marked transaminitis. Because there's a long half-life, it takes a long time to recover, so that's a big problem in terms of toxicity. But intriguingly, in a subset analysis, which was planned sort of after the study started, so it doesn't include all of the patients, you can see there's 87 and 113 with PI3 kinase mutations, but they checked this in blood. And when they did this study, looking at circulating tumor DNA in blood wasn't as accepted as it is now, although we're still missing some of these mutations in tumor when we look at blood. What you can see here is a marked difference, 3.2 to 7 months, kind of the range of difference we're seeing with other targeted agents in endocrine responsive cancer with the addition of buparlisib. But because of toxicity, this couldn't be pursued further. But because there was already a study ongoing looking at patients whose cancers had progressed on everolimus, so here we're targeting the same pathway. We're looking at patients whose cancers progress on everolimus, and we're adding in a PI3 kinase inhibitor to hormone therapy. And to fulvestrant. And what you can see here is, again, in the mutant group, and if you look at the bottom curves in circulating tumor cell-free DNA, you can see, again, a marked difference in progression-free survival on the kind of range we saw in BEL-2, and also we saw that in tumor tissue as well. So there were two important conclusions from this trial. One is that these agents may be very efficacious in patients who have PI3 kinase mutations. And I think particularly important for our patients, we can look at blood, and it may not be perfect, but it's really easy to get a blood sample. It's not very expensive, and we may be able to do an initial screen in blood and then decide whether or not we're going to put a patient through a biopsy in order to determine their PI3 kinase mutation status. Now, of course, we still end up with the fact that buparlisib was too toxic to continue studying, and pictillisib didn't have efficacy. So then we went to the alpha-specific or beta-sparing PI3 kinase inhibitors. And actually, there are 2 phase 3 trials which have completed accrual, and we're looking for results this year. So later this year, we haven't seen any yet, from Sandpiper and SOLAR-1 with tiselisib and alpelisib. Having used alpelisib in a number of patients in a phase 1b trial, I actually have patients whose cancers had already progressed on everolimus, 3 patients who remained in remission at 4 years, and one just progressed in liver, but she had a CR in liver after progression on both letrozole and exemestane everolimus, and has a PI3 kinase mutation. So these agents, I think, are going to offer an important additional resource for our patients, but we need to see the results of the phase 3 trials. And biomarker analysis is going to be even more critical here than in any other disease subset we've studied in hormone receptor positive disease. There are new agents that are looking at combining different targets, and there's an interesting agent, unfortunately given all intravenously, called gedatolisib, we've been studying. It's a combined PI3 kinase mTOR inhibitor given in combination with palbociclib and either fulvestrant or letrozole after progression on palbociclib. And again, we've seen dramatic responses, and in some patients more than a year, even after progression on multiple agents. So I think that we're still in a very much an exploratory phase in looking at inhibiting this pathway. Now, of course, the area I think which has gotten the biggest press in the last 3 years has been selective CDK4/6 inhibitors, of which there are now 3 drugs approved in the United States, a very fast progression of drug approval and data acquisition. Palbociclib was the first approved, then ribociclib and abemaciclib. The details of these drugs are listed here. As you know, palbociclib and ribociclib are given on a 3-week on, 1-week off schedule, and abemaciclib is given continuously as it has less blood count suppression. We have seen, it's an interesting kind of buzzing on there on the screen. Keep everybody awake. So there are a number of different completed trials, and they're shown here. We're still waiting for some of the data from ribociclib. And FDA approval status is also listed at the bottom of this slide. This shows you the marked difference in progression-free survival with the addition of a CDK4/6 inhibitors, and what's striking here, if you look across at the hazard ratios, and you can see that again in the next slide, the hazard ratios have been strikingly similar with the three different agents, suggesting that all of the agents have similar efficacy, even though there are differences in trial populations across trial, with about a doubling in progression-free survival compared to endocrine therapy alone. And this summarizes the phase 3 first-line studies in hormone receptor-positive metastatic breast cancer. I'm not sure what's going on with my slides. Just wondering if I should take a brief stop since you can't
Excuse
see
me.
it that way.
We have a problem here. I'm sorry for that.
Albert,
Doesn't show up on my screen.
Mr. Albert from Audiovisual.
Hopefully nobody has a low seizure threshold. I know that's not me. We seem to have lost our power. What to do? I don't have a microphone anymore either, but should I just talk? Okay, we're resetting. In any case, in the first phase 3 first-line studies in hormone receptor-positive metastatic breast cancer, the hazard ratios generally are about 0.5 to 0.55, and what we've seen is this doubling. Now, we updated the Paloma-2 data with longer follow-up, and now we have the longest median follow-up of any trial, because, of course, it was the first trial to report. And the progression-free survival now is almost 28 months in the treatment group. And that's certainly the longest progression-free survival we've seen in any patient group with hormone receptor-positive metastatic breast cancer. Also, we've looked at the, I don't know if it's better to just turn it off if it's going to flash, because it's too hard for people. In any case, there was an interesting study actually also presented and published within the last year that looked at, oh, now we have it, fulvestrant in patients who had no prior exposure to endocrine therapy. So this is an interesting group of patients because they have to have had a de novo metastatic disease or refused to receive endocrine therapy in the early stage setting. Some of these patients had actually received chemotherapy prior to their endocrine therapy. As you can see, the difference in progression, maybe you can see it, the difference in progression-free survival is quite modest in patients who had, in the general population, including patients who had visceral disease. But if you looked at the group of patients who had no visceral disease, so they had bone or soft tissue disease, you can see an improvement from 13.8 to 22 months, which is similar to the progression-free survival seen with the CDK4/6 inhibitors. I just have no idea what to do about it. I'll just keep talking. So that's actually an interesting question about whether or not we should be considering this as a guideline to which patients don't need to receive CDK4/6 inhibitors. I think you have to turn it off. I don't know what to do. What do you suggest? Because this is too distracting. Wait a few minutes. Yeah.
Just for working for the technology, the flashing is very distracting for her, for our guest speakers. So please, if you not fixed now,
Just turn it off.
turn off for 5 minutes and then fix it.
Maybe they'll fix it now. In any case, I'll just talk while we're going forward. But so I think that that's been received letrozole or palbociclib. Now maybe it isn't. Something that says activate Windows on the bottom. Anyway, if you look left of one, suggesting that there is no significant subset difference. And in fact, isolated analyses looking at patients with visceral disease have shown that there's an improvement in patients with visceral disease with a similar hazard ratio, although overall the prognosis is worse compared to patients who have bone-only or soft tissue disease. So that would suggest that you really have to isolate out a group of patients who have a very good prognosis with hormone therapy alone, and that may not only be the patients with bone-only disease or soft tissue disease, as were shown in the Falcon trial, and we'll talk about that in just a moment again. But the 22 months is still impressive in the Falcon trial using fulvestrant in the first-line setting. If you looked at a subset analysis recently presented in Monarch 3 at San Antonio this year, they actually looked at a different number of groups of patients based on prognostic groups to try and understand whether or not there could be a benefit in one group that was higher than another group. So in this group, they actually, the patients with visceral metastases and particularly liver metastases had a poorer outcome. But what they saw actually, despite the fact that the purpose of the presentation was to demonstrate that they saw better impact in liver mets than no liver mets, and little impact in bone-only disease, the hazard ratios were very similar across the disease subsets, and they hadn't reached actually the median follow-up in the majority of subgroups. So in fact, what I learned from this was in fact that the CDK4/6 inhibitor abemaciclib was effective across different disease subtypes. We actually looked at subset analysis in patients in Paloma 2 and presented this data at San Antonio this year, and in fact saw a very similar difference in terms of progression-free survival in patients with visceral metastases and non-visceral metastases. And you can see the step analysis on the right, where you see actually the differences are quite similar in patients regardless of whether or not they had visceral metastases. So what are the other differences that we might think about in terms of deciding which patients need what kind of therapy? Potentially toxicity would give us an idea about who might benefit from one therapy versus another. What we can see is that the incidence of grade 3 or greater neutropenia is about a third in abemaciclib that it is with palbociclib and ribociclib, whereas you see a significant grade 3 diarrhea of 9.5% in patients receiving abemaciclib. All-grade diarrhea with abemaciclib is 80% compared to about 30% with the other two agents. In ribociclib, we've seen a small number of patients who have QTc prolongations, but this appears to be quite uncommon, and with EKG screening, not a big issue. Dose reductions and discontinuations due to adverse events are quite similar across the three agents, with the exception of discontinuation for abemaciclib, which reaches up to 20% because of diarrhea. And then all of the agents, about a third of the patients have alopecia. One of the interesting things about abemaciclib is that creatinine goes up, and creatinine goes up in about 98% of patients without any impact on renal function. It's an interference in colorimetric analysis. We've also looked at biomarkers. Interestingly, some of the slides, as long as it's not a table, seem to work. It doesn't like Excel. So the biomarkers are shown here, a median progression-free survival in patients with intrinsic molecular subtypes. And what you can see is what you would expect, which is that the benefit is higher in patients who have luminal A and luminal B disease versus those patients who tend to have more hormone refractory type cancers. Now, whether that would mean that we wouldn't treat patients, I don't think that's the case. The numbers are very small, and you can see the basal subtype, there's only one patient in each group, as you would expect, same with normal. HER2 enriched is an interesting subset, and those patients may have mutations. Okay. It looks now different there than it does here. Can you go back one? So CDK inhibitors, whoops, no, back one. Now, okay, great, good, thank you. Okay, CDK inhibitors have also been, of course, tested in endocrine pretreated patients. Okay. No, I gotta look at this, though. I'll look at this, we'll be good. Apparently it has something to do with the computer. And you can see here that there's big differences between these two groups. Paloma 3, a third of the patients had prior chemotherapy. Monarch 2, none of the patients had prior chemotherapy. And primary endocrine resistance and secondary endocrine resistance were defined in similar ways. These show you the results in patients who were treated after progression on prior non-steroidal aromatase inhibitors. And what you can see is that, again, if you look at the hazard ratios, they're very, very similar despite the differences in the absolute progression-free survival. Hazard ratios, again, are about 0.5, 0.55. And what's fascinating is that's the same is true with everolimus. So maybe in our algorithm, what we're thinking about is using the least toxic agents, which would be CDK4/6 inhibitors, up front, and maybe saving agents which have equal efficacy in the second-line setting in terms of hazard ratios for later-line treatment. There have been no biomarkers that predict benefit or resistance in any of these trials and no differences in the subset analyses. Now, one of the subsets that's been quite interesting is what to do with premenopausal women. I think to the disappointment of all of us, the trials have largely excluded patients who are premenopausal but who are on GnRH agonists. However, there are now 2 data sets and a phase 3 prospective randomized trial. In Paloma 3, in pretreated patients, 108 women were treated with fulvestrant plus ovarian function suppression, and they had similar efficacy and toxicity with the addition of palbociclib. And then Debu Tripathi presented Mona Lisa 7, the only randomized prospective trial looking at the addition of a CDK4/6 inhibitor, ribociclib, in 672 premenopausal women who were treated with either tamoxifen or a non-steroidal aromatase inhibitor plus ovarian function suppression, and then ribociclib or placebo. And I think what's important in this trial is not just that we're treating premenopausal women, but a quarter of the women received tamoxifen. So that would also be an option for patients who don't tolerate non-steroidal aromatase inhibitors well. The efficacy was similar to Mona Lisa 2, as of course we all knew, but we needed to prove, with 24-month progression-free survival in the patients who received ribociclib, and the hazard ratio is identical and the hazard to the postmenopausal women, and the hazard ratio also was similar between tamoxifen and the non-steroidal aromatase inhibitor. And then the US FDA presented a pooled analysis in patients who were older, so-called older rather than elderly, in a retrospective subset. And you can see here that they looked at first-line therapy with aromatase inhibitors plus CDK4/6 inhibitors. It was 329 of almost 2,000 patients who were 70 years or older. Interestingly, 52% had de novo metastatic disease. That's the highest we've seen in any trial. So it does suggest that older women tend to present later with their disease. There was no difference in the efficacy across age subgroups, regardless of the age cutoff. They did, however, show some differences in tolerability and safety. As you can see here, there was an increase in grade 3 to 4 adverse events and no difference in grade 1 to 2 adverse events. So it tends to suggest what we see already is that the intensity of toxicity is a little bit higher, and then about double the number of patients had adverse events leading to discontinuation. I think what's encouraging to me actually is even with the SAEs being doubled and the AEs leading to discontinuation, it's still a minority of the patients, and this is definitely a treatment option for our elderly patients. Now, one interesting subset as well is the CNS response with abemaciclib. Actually, there's now preclinical data that suggests that all 3 CDK4/6 inhibitors cross the blood-brain barrier and have appreciable concentrations in brain tissue. However, abemaciclib is the only trial to study this prospectively, showing a small number of patients with response, as you can see in the blue lines there, and this study is ongoing. So it does suggest that there may be a subset of patients who have a predilection for CNS metastases who may benefit from these agents, and this was given as a single agent. And this shows you a responder. Of course, we always show the responders. This is a patient who had prior treatment with radiation, and you can see with single-agent abemaciclib a significant shrinkage in her disease over 12 cycles, so this is over a year. So when we're thinking about using an algorithm to treat patients, it's important to understand resistance. So could we select a patient group who are resistant upfront to CDK4/6 inhibitors? So far, de novo resistance is hard to detect. Now, that may be because we have such a dramatic impact on progression-free survival and very high response rates, but so far we really haven't understood which patients have de novo resistance, other than a very small number of patients who have absent RB. You need RB or retinoblastoma in order to respond. However, acquired resistance, we're now seeing a huge number of papers looking at acquired resistance, very interesting data, suggesting, of course, RB alterations can be acquired in these tumors, although it still is a minority of patients. Much more commonly, we see amplification of cyclins, S-phase CDKs, including CDK2, and overexpression of cyclin E, and amplification of cyclin D1 and cyclin E. Upregulation of signaling pathways that induce cyclins and CDKs have been a new and emerging area of resistance, including PI3 kinase, the fibroblast growth factor receptor, and RAS. So in future steps, I think what we're really trying to look at is how we should use these agents and how we should best develop an algorithm. There's an interesting study which has already completed accrual in almost 500 patients called Parsifal, using fulvestrant versus an AI as first-line therapy for metastatic hormone receptor positive disease to try and capitalize on Falcon using fulvestrant and then add in the CDK4/6 inhibitor. Maybe people will have a progression-free survival exceeding 3 years in that group of patients. And then there are studies looking at CDK4/6 inhibitors after progression to see whether or not it could be like trastuzumab-like and still benefit response. And then there are a number of other studies listed here looking at a wide variety of different agents, and we're participating in a study run by Vanderbilt with an FGFR inhibitor along with a CDK4/6 inhibitor as well. And we recently presented pilot data looking at the combination of CDK4/6 inhibitor plus a checkpoint inhibitor. On clinicaltrials.gov, there are over 100 active studies. Early stage disease, there will be over 10,000 women randomized on trials. The Penelope B trial in post-neoadjuvant high risk just completed accrual in December of last year, and the other trials are actively accruing with palbociclib, abemaciclib, and ribociclib. So an algorithm is ever changing. With the future scope in on mode, we could look at patients who are more than 12 months from adjuvant AI or de novo metastatic disease. I would still favor an AI with a CDK4/6 inhibitor, less than 12 months, fulvestrant. With treatment after progression, on ESR1 mutation, you could use fulvestrant and exemestane versus everolimus, and fulvestrant and everolimus versus everolimus and exemestane, but probably we don't need to test because it's reasonable to switch to fulvestrant after an AI anyway, so you could save the expense of testing. In mutation-based therapy, we may see PI3 kinase mutations that are acquired or FGFR mutations, which I'm seeing more commonly. And I'm also seeing loss of ER with progression as a common mutation in patients who have progressed on CDK4/6 inhibitors. And I think that will be an interesting area for exploration. Who we wouldn't treat, maybe these are older patients who have a single bone metastases or limited soft tissue disease or de novo bone-only disease. And that would lead us to an algorithm here, which I'm happy to provide, and we'll skip through just due to time, where we might think about trying to triage patients based on the state of their disease, their pace of recurrence, and then in the future, I believe, mutation testing that will help us understand which the next agents we should use are in which patient group. The future of treatment in hormone receptor positive HER2 negative advanced breast cancer involves targeted agents, and I think we'll be using this in most patients in the future, despite the expense, and hopefully by moving them to the early stage setting in an educated way, we'll be able to prevent our long-term recurrences. Thank you very much.